Welcome to Louisville Lectures Pediatric Emergency Medicine Lecture Series.
Let's talk about heat illness. So, objectives for today will be to recognize heat illness and its associated environmental as well as patient factors. We're going to discuss and distinguish heat cramps, exhaustion, and heat stroke, and explore relative management strategies. So let's start with a case scenario. So it's a summer day in the emergency room. An EMS call comes in, and it's about heat illness, and unfortunately, it's a child victim. So a wellness check was performed, and there were several children found in a trailer, and that trailer did not have air conditioning. And this was actual case, and this was when I was working in South Florida. So one infant, unfortunately, was found deceased at the scene, but there's a 2-year-old at the scene in the trailer, and that child had a temperature of 103 degrees Fahrenheit. So as we go through this, let's keep that kid in mind and also just keep other patients in mind. So there is something that's kind of an easy throwaway here that I wanted to talk about before getting to other types of heat illness, because there are basically in the textbook 3 kinds, but effectively there's really 2. So first one is heat cramps, and this is an easy one. So these are just brief, intermittent, severe cramps. They typically are associated with significant work. So someone's doing a lot of exercise outside. They're not really acclimated to the activity or the conditions, the heat. And typically there's water and salt loss, so only water is traditionally replaced in these patients. So they can have some hypochloremia and hyponatremia. You could also see an elevated BUN, but usually that's normal. They're typically not that far along. What their main distinguishing feature is really just these cramps. And so most of these cases are mild, and they can be treated with some rest, and you can give them a little bit of oral salt intake. So electrolyte solutions, salty food. These are patients still capable of taking oral intake. And if this is a severe or prolonged cramps and that's not working, you can do a normal saline bolus, 5 to 10 cc's per kilo over 15 to 20 minutes is what the textbook recommends. Now, the next thing is really a broader umbrella, and that's heat illness. And so you have heat exhaustion versus heat stroke. And this is really 2 illnesses, but it's generally a spectrum of illness with a really clear demarcating line. And you're talking about a continuum of disease, and there will always be some overlap when you look at patients here. So it's not necessarily always obvious what you're seeing if you look at all of the different factors, but there's one defining characteristic, and we'll get to that. So heat illness is basically disordered heat management. We accumulate heat and we dissipate heat. And if we're either accumulating excessively or we're failing to dissipate appropriately, then we're going to run into some problems. So how do we accumulate it? Basal metabolism. We're mammals, so we produce heat with our just being alive, basic basal metabolic rate. You also, when you do work, produce heat, so activities will do that. It might sound silly, but the sun, basically, you can have solar radiation warm you up, so that's why when it's hot out, we all prefer the shade. And you can effectively cook people. We don't think of it this way, but that's what you're kind of doing with a sauna or a hot water tub. You're putting them in something that very similar to steaming or boiling vegetables. You're increasing the temperature there. Now, most of us will maintain our temperature appropriately, but that is the stress you're submitting people to. You can also just have an elevated body temperature because you're febrile or ill for some other reasons. And dehydration also. Your body dealing with dehydration does increase your basal metabolic rate. Similar to the cooking thing, you can have an environmental elevated air temperature. So this isn't steam per se or hot water per se. It's just the air you're in is particularly hot. So how do you get rid of that heat? Well, radiation and conduction. And so the air in the environment have to be cooler for that to work. So someone trapped in a hot car, unfortunately, that hotter environment cannot cool them by taking their extra heat. Now with evaporation, sweating, you have a lot of ability to get rid of energy, get rid of heat by having that phase transition from liquid to gaseous water. Unfortunately, it's impaired by humidity. So the heat in you being transferred to liquid water that then becomes gas, that requires it to go from liquid to gas. And so if there's a high humidity outside, it's harder to do that. Also, if you're not having evaporative cooling, but just the sweat is dripping off of you, that doesn't really count. That's not really getting rid of that much heat. So physiologically, what do you do? So your cutaneous vessels dilate, and that helps to shunt blood to your surface, to increase your surface area for cooling and the volume of blood going through there. But that does require your cardiac output to increase. So you'll have decreased peripheral vascular resistance so that blood can go to the cutaneous vessels. And cardiac output can double or quadruple, so it is quite an extra demand on you. Now, you will also have splanchnic vasoconstriction to kind of compensate for that, so you may not have as much blood flow to your viscera. Sweating increases, meaning it's not just the blood going to the skin, but also the sweat glands are producing more sweat on the skin so that can have some evaporative cooling effect. And if you're acclimatized to heat, you can actually have a physiologic acclimatization to heat, and want to discuss that a bit. So this is not a process that happens right away. And first things first, we're tropical animals, so we don't really acclimate to cold, but we do acclimate to heat. And it usually takes a good week or two for you to do it. So you can't just have a bunch of physical activity in one day and this happen. And it usually requires some exercise for you to do it. Now, the mechanism isn't exactly understood, but it is thought to be via the renin-angiotensin system. So you have increased aldosterone production and thought that sodium gets retained in your urine and blood, but this also means that you increase a lot of potassium secretion and excretion rather. So you will sweat more, and you will sweat at lower body temperatures. So it's kind of ironic that someone who's exercising and gets used to it might actually be sweating quite a bit more, but that's because their body knows that exercise is coming, that temperature increase is coming, and it's preparing, it's doing what it can sooner. There are also, a lot of these folks have increased mitochondria density in their muscle, but that might also just be that they're related to the activity. So classic case that we see in late summer is the football players running out full gear, they're out of condition because they haven't been playing and the season's just starting up, and they go out in the hot sun, they exercise a whole bunch, they're not conditioned to it, and they can't sweat anyway because they have all their gear on. So this is kind of a classical stereotypical presentation of someone who's risk for getting a heat injury and heat illness. About that acclimatization, that increased potassium excretion, for those of you that like to run, you might have noticed that they love to give bananas out at the ends of races. I can't help but think that must be related. Get some energy back in you, as well as some potassium. So cardiac output, we all remember, it's stroke volume times pulse rate. So what happens when you acclimatize? And the reason we're spending time on this is because it gives kind of an idea of the types of people that can't accommodate or just haven't prepared to. So there's specific cardiovascular adaptations. There's increasing cardiac output, as we mentioned, because you're sending a lot of blood to your skin now. And so your heart rate is not typically the main lever for that. It's more of an increased stroke volume. So what you see is it larger stroke volume, and it's really not the pulse rate that's going up. So what's going to set you up for trouble is going to be the types of people who struggle at doing these things to acclimate. And also to just deal with excessive heat. So the elderly can't increase their cardiac output often. They often are dehydrated, and they may even have cardiovascular diseases that impair their heart from functioning the way you'd want it to in terms of improving their cardiac output. Neonates just don't really thermoregulate very well at all. They can't sweat, and a lot of kids, their cardiac output is more dependent, particularly the younger ones, on pulse rate as opposed to stroke volume. Unfortunately, if you have an obese patient, that increased insulation can make it challenging, as well as a decreased surface area to volume ratio. If you're hyperthyroid, or really any condition that will increase your basal metabolic rate, that can be a liability because you're producing more heat there. And with respect to sweating, there's quite a few dermatologic diseases that impair sweating, and that can make it challenging. Cystic fibrosis is also a condition where, because you have impaired issues with some issues with faulty ion channels, what you expect to see and what you want to see in terms of being able to do things like sweat effectively, unfortunately, can be a challenge. Medication considerations too. So to discuss some of them, diuretics, you're going to be dehydrated, so that can be a challenge. If you're taking beta blockers, that can also impair your ability to increase your cardiac output, and stimulants can increase your activity and thus your heat load. Anticholinergics reduce sweating as well as, and so that also can be a liability with respect to getting rid of excess heat and setting you up for risk for heat illness. So heat exhaustion versus heat stroke. So I mentioned earlier that there are a continuum of disease, but spoiler alert is it's really the CNS symptoms that are the distinguishing feature that tell them apart. So while they're not exactly truly separate disease processes, there are some generalities, and for one of them is really it's the heat exhaustion. They're uncomfortable but compensating. So sweating versus not sweating, you can find some things in both heat exhaustion versus heat stroke symptom-wise. While we will discuss them, the big symptom that you need to know is CNS symptoms, and significant ones. And that's because in heat stroke, compensation's failing. So that's really when you're starting to see end organ damage, and the CNS symptoms are the ones that will be most obvious. They might both be sweating. So heat exhaustion, generally this is compensated. And so there's two types. Water depleted, which is the most common, and that's someone who's just not replacing water adequately. And with sodium depleted, they might be active and out there and replacing their losses, but they're replacing it with water, and so they develop a sodium deficit. So heat exhaustion, core temperature up to 105.8 is possible higher end, but they rarely get that high. They usually typically are more like 39 degrees Celsius as opposed to 41. But you can see that happening in heat exhaustion. That's not abnormal. How I mentioned it's a spectrum of illness is that the cutoffs for temperature, there really aren't any for this. You can have significant overlap, although there are problems when you have heat stroke and an organ failure and you start really just failing to compensate and it really gallops forward. But that's why talking about these symptoms is fine, but what you really need to remember is CNS function is intact in heat exhaustion. So they might have symptoms like headache or malaise or muscle cramps or nausea, vomiting, and anorexia. They can have orthostatic hypotension or tachycardia or diaphoresis. They can have pyrexia, but remember that CNS function is still intact. Even if they're lightheaded and hypotensive or dizzy, CNS is intact. So with respect to labs, they might be hemoconcentrated. We mentioned that there's two types. So they could either have water depletion or sodium depletion. So they could be hypo or hypernatremic. So we need to be mindful of that. And so with them, generally speaking, when you're dealing with heat illness, there's going to be three things that you do. I'm saying this out loud because you don't necessarily obviously, it may not seem obvious, that's what you're doing in some of the milder, but when it becomes the severe heat illness, it really is more of a direct thing you have to do. So you're going to support their cardiovascular system. So if they are dehydrated, you can give them some liquids. You might need to correct metabolic abnormalities. We saw those bananas being handed out at the end of a race. That's nice of us. Removing excess heat, let them sweat, take off extra clothing, fan them, etc. But this can be quite invasive with the more severe illness. It may not be quite as simple as those supportive things. So with heat exhaustion, that's more conservative management than heat stroke. So fluids, and typically that's enteric. Let them rest in a cool environment. I see that patient there is out of the shade. You can give them some sugar, some way, shape, or form if they need it. Monitor for rhabdomyolysis. And check those neuro exams because we really don't want to see CNS deterioration because that gives us an idea that this person's no longer compensating and they've now progressed from heat exhaustion to heat stroke. So water predominant, drink cool liquids. We do not restrict sodium intake in the water predominant folks. And you can give IV fluids if necessary, but if you're doing that with both water predominant or sodium predominant, you are going to be mindful that you don't want to rapidly correct sodium unless one specific scenario we're going to discuss in a moment. So for sodium predominant, you're going to have them drink cool liquids. They can have some salty ones, not hypotonic ones, so don't give them water. They're going to get something like an electrolyte solution. And if it's necessary, you can give them IV fluids. But you're not going to want to correct them if they have a hyponatremia very quickly, with one exception. And it's not a full correction we're talking about. But if someone's having hyponatremic seizures, that's different, and that could happen in this scenario. But if that's the case, and they're having intractable hyponatremic seizures, which from my personal experience, hyponatremic seizures tend to be intractable until you at least partially correct, the recommendation is 3% hypertonic saline, 5 cc's per kilo over 10 to 15 minutes. But once they stop seizing, you stop giving it. You really don't want to correct all of the hyponatremia too quickly, or you can have other problems develop. So heat stroke, we're moving right along here, and that is generally uncompensated. So in scenarios of heat stroke, you have compensatory mechanisms failing. And so now you're not supporting them. They're failing, and it's no longer a matter of simple support. It's more interventions we're going to discuss here. So precipitating factors, dehydration and hypokalemia can set you up for it, as well as relative hypoglycemia, anything that decreases sweating, as we discussed, and if they have high output cardiac failure. Basically, We discussed what sets you up for this, and unfortunately, though, in these situations, we might have to be a little more assertive about our interventions. So what temperature? There's not really a cutoff. We did discuss previously 39 degrees Celsius common with heat exhaustion, as well as up to 41 degrees. Now, oxidative phosphorylation uncouples at 42 degrees Celsius. So if someone's getting that hot, they're really in danger. But the definition of heat stroke relative to heat exhaustion, it's still CNS dysfunction is the key feature. And with respect to heat illness, we have discussed electrolytes and fluid balances, but the reality is that they may not necessarily be depleted. It really depends how long it took them to get that hot. And so core temperatures can rise rapidly, and you can see cellular damage without necessarily having any issue of fluid deficits or other metabolic derangements. So with heat stroke, they're uncompensated. So the CNS dysfunction, we're not talking about someone who's orthostatic or dizzy. We're talking about delirium, ataxia, seizures. They'll progress to coma and death. So this is a lot more concerning. And you can see some interventions being done there. There's a victim who's in an ice bath, and that we'll talk about momentarily. So what else might you see in these patients when they have CNS dysfunction? They'll have dry, hot skin possibly, although they could still be sweating. That's not a guarantee. Tachypnea, hypotension, sinus tachycardia. So if you remember how we were talking about how you need to support them, there's cardiovascular support. You need to correct metabolic derangements and also get the heat out of them. So other complications that come with this, renal damage and failure, muscle damage, they can get rhabdo. You can notice myoglobinuria, hypoglycemia, hypocalcemia, that can happen as well. They can have hepatocellular injury. They can become coagulopathic as well. So the main point here, and I've probably said it enough that this doesn't really bear repeating, but I'll do it anyway. If a patient with heat illness has CNS dysfunction, you're dealing with heat stroke, and heat stroke is life-threatening. You're going to be more invasive with what you do there. So one more graphic just to make this point. So heat exhaustion, commonly dizziness, thirst, heavy sweating, nausea, and weakness. Whereas heat stroke, you can still have dizziness, but confusion, unconscious, that's more concerning. So you can see with heat exhaustion, they act fast to do supportive care, and if they're not improving, there's concern they're progressing to heat stroke, so they seek medical attention. Heat stroke, straight to medical attention. Not that you don't do the supportive care in the field, but that you know you're in the danger zone. So this is just another chart also to make that point. And the big thing with this chart is that CNS function, CNS signs is the distinguishing factor. These temperatures, it's all usually, often, maybe it's the CNS dysfunction that is the distinguishing feature and characteristic. So how do you treat them? Mentioned those main principles before, treating hyperpyrexia as well as cardiovascular support and metabolic derangements, you'll correct them as well. So how do you do that, the rapid cooling? So let's say you get a call from EMS. You're going to ask them to do certain things. So they can remove the patient's clothing to try to assist with evaporative cooling. You can fan them. You can put, and tap water's cool, so that if you're spraying cool tap water on their skin and having evaporative cooling, that can help to get some of that heat out of your patient. You can also put cool packs on the neck, axilla, and groin. Those are where some large vessels are, and that can help to cool the patient as well. If you have cool water immersion, that's an option. Not something that you want to delay transport for necessarily, but that is something that might be possible, might be available. And if the patient is altered, it may be unsafe to give them things orally. So if you're trying to give fluids, that may not be something that you can do enterically. Generally in these patients, you're not thinking enteric gentle support. You also want to transport them as quickly as possible because some of the things they might need can be quite demanding. So, evaporative cooling. In the hospital, you can still do those things that were happening via EMS. Evaporative cooling, you can have forced air blowing over the patient. Immersion in an ice or cool water, that can be achieved by putting them in a body bag packed with ice. IV fluids, even chilled. And you can do ice water and nasogastric lavage. Now, let me go back to that. If you remember, splanchnic vasoconstriction is something that tends to happen when you are having heat illness or heat stroke. And so you have a lot of your blood going to the skin. So while you can do an NG lavage, that may not be there may not be much perfusion to the viscera, so it might not cool them as much as you might hope. So with heat stroke and hyperpyrexia, you'll need a continuous rectal temperature, and all techniques in the previous slides are still fair game for these guys, but and we mentioned the chilled fluids. Now, I don't know if this is very well demonstrated in pediatrics, but it's been shown in adults. There's also iced peritoneal lavage, not really done, but in the same way that you can provide peritoneal dialysis, you can also put cold water peritoneal and try to get some of that heat out of them that way. You can't do it in someone with a history of abdominal surgery, though. Sedation and paralysis can help to cool them as well. If you have someone where they're worried about some kind of metabolic uncoupling, sort of like hyperpyrexia from a sedation interaction, or if they're active still and moving, you can do that to try to decrease their activity level. ECMO is always a way to try to fix temperature abnormalities in a patient rapidly as well. In terms of cardiovascular support, IV fluids again for hypotension. And if you notice metabolic abnormalities, you should correct the electrolytes. We mentioned sodium previously. You don't want to be aggressive and too quick about that, but make sure calcium and glucose are fine. If you do need to give inotropic support, you have to think about what happens when you give things like epinephrine and norepinephrine. Now, normally when we do that in a code situation, it's because I'm trying to have some peripheral vasoconstriction so I can really support their heart. Now, that might be a liability when someone's problem is that they have been exposed to heat excessively, and I'm trying to get that heat off them, and that peripheral blood shunting is one of the best ways to try to cool them. So dobutamine is preferred as the beta agonist of choice because it does increase your myocardial contractility, but you're not going to impair that peripheral vasodilation that you need for your cooling efforts. Epi and norepinephrine are alpha agonists. Their alpha agonist action makes them less preferred because of that vasoconstriction peripherally. And once again, ECMO is an option. So this is a clinical diagnosis. It doesn't really require labs, but as we mentioned, you do want to correct your metabolic derangements. And so here's some labs that may be useful: CBC, CMP, creatine kinase, because you're looking at muscle lysis. Also, you might note myoglobinuria in your urinalysis, and you can check for coagulopathy. If they're on a thinner, you can check an INR. Lactate as well to make sure to check end organ perfusion might also be helpful for trending. EKG and troponin if you're worried about cardiac insult as well. Now, we talked about some of these cooling methods, and I talked up skin, and there's a reason for that. If you look at the different ways that you can try to cool someone, you have cold inhaled air. It doesn't really do a whole heck of a lot. Ice packs are pretty helpful. Gastric lavage, not terrible, but this does require some work. Ice water bath, not bad either. Evaporative cooling, well, that's pretty money for something that's relatively uninvasive. And then peritoneal lavage can be pretty helpful too. The reality is people don't really do that much anymore. I've never personally seen it. So what about that kid we started talking about in the beginning? So EMS placed that kid in a kiddie pool at the scene prior to transport. So by the time I saw this kiddo, normal vitals, normal exam. Truth be told, I actually got this kiddo sign out, and when I saw them, they were great. My colleague who got them before me also looked great for her. We both were subpoenaed in this case, and it didn't actually go to trial because unfortunately, because that one infant was lost and there was a lost. This went to a prosecution. The responsible parties pled guilty. So this child, though, got to be safely discharged after brief observation, but for reasons stated, not to the same home. So that's the references and acknowledgement. Thanks for your time and attention.